All right, so this session is called Care Models That Prioritize Behavioral Health. I'm going to begin by introducing Barbara Burnett, who helped plan the session, and Barbara's the Chief Medical Officer and Senior Vice President with Mount Sinai Beth Israel Medical Center, New York Eye and Ear, and Mount Sinai Downtown, and she's board certified in emergency and internal medicine, and practices as well as being the residency director. One of the things that you said in your intro is that you like mentoring people, and she's been the best mentor of MHCDS alums through her, just all of her. She's committed so much time and so many hours to so many symposia, so it's just great. I'll let you take it over from here, but thanks,
Thank you so
Barbara.
much. Appreciate that. Thank you so much, Molly. Good afternoon. Actually, it's still good morning, right? Good morning. Oh, come on. What an anemic response. Good morning. Good morning. Okay. Now we're going to get started. We're going to reimagine how healthcare can be delivered. So let us get started. So if this wasn't a burning platform, mental health illness before the pandemic, it surely is now. Next slide, please. It's a crisis. I'm going to talk a lot about what's going on in New York City, but I'm sure it's going on in your city as well. So the link between violence, crime, and mental illness has mounted. I know Sabina and Will and I have discussed it. Some of the early studies were challenging. You couldn't really, the way they gathered data, the groups they included, weren't the best of studies, but there is a link. And I don't think we can argue that. Even if you control for factors, demographic factors, socioeconomic, educational level, there is a link between mental illness and violent crimes, especially in untreated and poorly treated people with mental illness, especially around patients who have psychosis, around patients who have schizophrenia. The nice thing about it, these patients, when treated, that gap goes away. There's a Denmark study, which I don't know how applicable it is to much of the United States, since they're a very homogeneous population. There's about a 7-fold increase in crime in patients who have had one psychiatric admission. Throw in alcohol, throw in polysubstance, and we have vastly rising numbers of crime. So these are some of the statistic rates for crime in New York City. As you can see, the numbers are just exploding. Next slide, please. New York City, we have been surpassed by Los Angeles. We are no longer the #1 city for homeless. We have fallen to second place. No surprise there when they decided to close all these psychiatric institutions. You know, this untoward effect. All of a sudden, we were supposed to build up an incredible ambulatory infrastructure that was going to help manage these patients in the community. That never happened. So, unfortunately, a lot of our patients with psychiatric and mental illness ended up on the streets. New York, I believe, has more sheltered patients. Los Angeles has a lot of street homeless, but they are #1 now. Next slide, please. So 1/3 of the homeless population has untreated serious mental illness. In major cities, they're part of our landscape. They ride the subways with us. They sit on park benches. They're in the libraries. Don't forget that these individuals have a mortality that's almost 9 times normal. They themselves are likely to be victims of crime. And there's high recidivism in and out of the jails. Next slide, please. So unfortunately, we had, based on a couple of high-profile cases in New York City, the mayor decided it was time to move the homeless out of the subway system. Not very popular. Next slide. Then, let's just clean up the shanty towns and get rid of those as well. So any degree of stability our homeless patients had was now gone. Next slide, please. Then, November 22nd, 2022, he decides to pass this mandate, insisting that NYPD and EMS involuntarily remove mentally ill patients from the streets and bring them to the hospital. I'm an ED doc. Bring them to the hospitals, even if they pose no threat. So I'm hoping my colleagues will speak more to this, but this was an outrage to many of us. Next slide, please. Then, so there's a burning platform already, pre-COVID. We've met in this symposium. We've talked about this before. We know it's an issue. Let's just throw some COVID on top of this and see where we land. So, post-COVID, next slide, please. Unfortunately, COVID, because of social isolation, grief, inability to get jobs, loss of others, it has hit our society, all societies. There's a 25% increase in anxiety and depression worldwide. Unfortunately, it's targeted our youth. For the first time, children less than 13, suicide has become one of the highest causes of death, along with accidents. Women tend to be affected more than men. Healthcare workers are affected, they think, surely because of exhaustion. If this doesn't serve as a wake-up call, I don't know what will. Next slide, please. These are the numbers of individuals screening for mental health. Staggering numbers. Next slide, please. Rates of, again, anxiety off the charts. Next slide, please. Suicidal ideation. But with all that need, with all that increase, we have a 10% reduction in inpatient psychiatric beds. Doesn't make sense. But I tell you one thing about the pandemic that helped. It's now okay in polite company to say the word mental illness. It's now okay to say that it is an illness. People are starting and willing to talk about it because it's so endemic. So is it all doom and gloom? Is there recovery ahead? Remember, this is an uplifting reimagining. So again, we got this. I guess somebody must have spoke to him about his prior mandate, and he decided he's going to give us some money to help support our programs. And again, that's another issue that my tremendous two behavioral health physician colleagues are right here. They're going to take it from me. I have one of your very own, Dr. Will Torrey. He is the chair of psychiatry. He holds the Raymond Sorbel Professor of Psychiatry. He is also a professor at Dartmouth Institute of Health Policy and Clinical Practice at Geisel. His professional interests include care of adults with severe mental illness, psychiatric rehab, and implementing evidence-based practices. Dr. Torrey is a member of the Dartmouth class of 1980, woohoo, a graduate from Harvard Medical School in 1985. He has held a number of leadership roles throughout his career, including the medical director of West Central Behavioral Health, medical director of the DHMC Department of Psychiatry, and most recently, before becoming chair, he was the vice chair of clinical services for the Department of Psychiatry at DHMC. In his current role, Dr. Torrey leads the Department of Psychiatry in delivering value-based care, education, and research programs for both Dartmouth Health Psychiatric Services and the Geisel School of Medicine at Dartmouth. Next, Dr. Lim. Now, Dr. Torrey will speak to us about solutions around the rural-urban, institutional, and outpatient. Dr. Sabina Lim is from the Mount Sinai Health System. She's the Vice President of Behavioral Health Safety and Quality, System Medical Director, Regulatory Government Affairs, and Professor of Psychiatry at the Icahn School of Medicine at Mount Sinai. Dr. Lim graduated from the University of Michigan with a BS in biology, received her MD from SUNY at Buffalo School of Medicine, and an MPH from Columbia University Mailman School of Public Health. She completed her psychiatry training at Yale University Department of Psychiatry and held various clinical and administrative positions at Yale, including the executive director of Yale New Haven Psychiatric Hospital. She joined the Mount Sinai Health System in 2013 as Vice Chair of Clinical Affairs for the Department of Psychiatry, and then served as Vice Chair and Chief of Strategy of the Mount Sinai Health System Behavioral Health Services from 2015 to 2020. Dr. Lim serves on multiple policy and advisory groups, including the New York State Public Health and Health Planning Council at the New York State Behavioral Health Services Advisory Council. Her expertise is in behavioral health services delivery, innovation, and redesign, value-based purchasing care models within the behavioral health population, behavioral health policy, and quality improvement in behavioral health care. Dr. Lim will share some solutions in an urban setting, including sharing of the new Rivington Comprehensive Medical Center, highlighting regulatory obstacles and solutions, and especially addressing pay disparity. So at this point, I'd like to turn it over to my colleague and friend, Dr. Will Torrey.
Hello. It's nice to get a chance to talk to you today on this, and I'm grateful that that we're focusing on mental health as part of this conference. There we go. All right. So these are photos of my children when they were young, and the one with flowers in her hair is going to medical school this summer, so it's a while ago. But the reason why I show these pictures is really to remind myself and all of you how crucially important and very personal healthcare is in general, and mental health care is in particular. Psychiatric illnesses are just incredibly common. If you yourself has not lived with mental health or substance use disorder, it's highly unlikely, and you're incredibly fortunate if someone you love has not lived with one of these disorders. About 20% of us in America have one of the disorders in any given year, and about half of us will have one of them in our lifetime. So I want to start by just emphasizing what you all actually know when you think about your own lives, that these are not things that happen to other people. These are things that happen to us and to our family members and to our neighbors. So the importance and gravity of what we're talking about is very personal, okay? So psychiatric illnesses are also extremely responsive to treatment. If you can get good treatment to people in a timely fashion, people can do exceedingly well. I've had the great fortune of meeting people who are extremely ill, who I've been able to care for over years and gather the right resources together, who are out, working full-time jobs, doing full lives, married families. There may be people in this room who have lived with very severe psychiatric illnesses and are currently doing really well because they were able to access good care in a timely fashion. So I think it's important to, again, start with us and the fact that there's no health without mental health. So in our state, John Broderick was the former Chief Justice of the Supreme Court in this state. He had a terrible incident where he was attacked by his son, who was quite ill, and he changed his career after retiring to go educate about mental health. And so he asked provocative questions like a good trial lawyer. So he asked me one time, how would I rate the quality of mental health in this country on a scale of 1 to 10? So this made me step back and think, well, what's 10 out of 10 care? So when I thought about that, I thought about my wife, who she was at Dartmouth-Hitchcock Medical Center for a routine mammogram, which was read by a very astute radiologist, saw breast cancer. Within a week and a half, she was in seeing the surgeon. She met the surgeon, she met the oncologist, she had a care navigator. It wasn't quite as sophisticated as what we learned at UAB, but is extremely good care. She got radiation treatment, oncology care, and she's 5 years out doing very well. But I have to say, the cancer care was not fun. It wasn't like an enjoyable experience, but I would have to say she got 10 out of 10 care here. So there are pockets in the United States where you can get 10 out of 10 mental health care, but they're very rare, and it's not a routine experience to be able to get that kind of care. We just haven't turned as a society towards these illnesses with the same level of respect and seriousness that we have devoted to other illnesses, important illnesses like cancer. You know, cancer touches all of our lives, and psychiatric illness touches all of our lives as well. It's actually shocking how difficult it is to access timely, high-quality mental health or addiction care. Even for ourselves or our family members, or our colleagues or our neighbors. So what we're talking about is really important. And it's not an impossible task to address either. We know that other illnesses like cancer and HIV were stigmatized, they weren't talked about, and then people turned towards them with seriousness, gathered the philanthropy, gathered the political will, gathered society to turn towards it. We are in a very different situation today than we were before. So I want my children, should they be in the need, to be able to walk in and get 10 out of 10 care, and I want that to be true for your children as well. All right, so this is just stating it on a slide. Oops, it went back. Very common illnesses, more than any one of us can address by ourselves. Part of the issue is funding. Part of the issue is that we haven't invested in the workforce that's needed, and that there's a widening gap between what's needed and what's available currently. And over half of people who have any psychiatric illness, including serious psychiatric illnesses, receive no care at all. And much of the care that is provided in primary care. And unsupported primary care often doesn't provide care that is of the quality that you would actually want for your family member or for yourself. So we're at Dartmouth, we're an academic rural health system. So what can we do to turn towards this challenge, which is fundamentally to seek to make sure that people can get timely access to high quality care. So we kind of go at it every way we can, so I'm just going to give a few examples of ways that we've done it. I'm going to talk a little bit about leveraging psychiatric specialty knowledge by embedding psychiatric care in primary care and specialty settings. Talk about deploying technology to touch more lives, talk about re-engineering care to make it more efficient and more effective, and building out the workforce in a strategic fashion. And that photograph is why we live up here. So to start with, as many people have across the country, we've implemented practices that have been demonstrated to be effective. So this is the collaborative care model that was started at University of Washington, where you screen for psychiatric difficulties through patient-entered data, and then for people that meet criteria, you have a team in place where you have a behavioral health clinician who works with the patient and with the primary care doctor, and extends the care, tracks the person over time, outreaches to them, measures how they're doing over time, so it's measurement-based care, and it's a stepped care model where you bring in more services if the person isn't improving as expected. So like the cancer example earlier, if you look for depression, you find depression, and then you can treat depression early and much more effectively. Here at Dartmouth, we chose to build it out not just for depression, but for screening and supporting primary care for depression, anxiety, alcohol use disorder, and other substances, including opioid use disorder, so that we can support the primary care system to provide evidence-based practice for all of these difficulties in all of our outpatient settings. So this is one way to leverage psychiatric knowledge to touch more lives. And the primary care doctors get better and better at doing the care themselves, and they can do more if they know we have their back because we're right there with them. Secondly, we likewise have been putting psychiatric care, psychology, and psychiatrists, psych nurse practitioners into just about any part of the specialty healthcare system we can. So the Dartmouth-Hitchcock Medical Center, we have care in the Cancer Center, in neurology, HIV, pain, spine, all over the place, so that if you're a patient seeking help there, you get team-based care that includes behavioral health care right where you are, because people tend to not follow up if you refer them to psychiatry. So you have to provide the care right where they are, and then their general medical outcomes are better as well. So this is a little bit broader, but just to, because I'm going to describe a project we did in Colombia, South America. Lisa Marsh was mentioned before. She was the PI in this project, but we had a 5-year NIMH-funded project which was technology-supported care integrated into primary care in Colombia, where there really was very little psychiatric care at all. It was focused on alcohol use disorder and depression. So there are 3 elements of the support. The first was digital screening in the waiting room. So the second was decision support that the primary care doctors had in their lap when they were seeing the patient. And the third was a digital therapeutic, so therapy over the computer, over your phone, through like having a therapist in your pocket. So I'm going to describe this a little bit more. So in the waiting room, people would put their cards in, their health cards, and they would be welcomed there, and they would be screened for depression and alcohol use disorder. The scores from those went to the primary care doctor on a piece of paper that the patient had, but also digitally onto a tablet. And the tablet was a decision support tool that helped them to understand how to interpret the finding and how to turn it into a treatment plan. And then patients who joined the study were given a digital therapeutic device that actually was a cognitive behavioral therapy that you could do on the phone, because there weren't enough therapists, obviously. So this was a way of helping provide care with a device. They could also do it at their local library if they had one, or at their hospital on a computer. So we went from, we were in 6 different primary care sites in Colombia. We screened over 22,000 people. This was nothing, just totally new program. And out of that, we made a diagnosis of depression in about 8% of the people just coming in for other reasons. And so we went from diagnosing no one for depression to about 8%, no one for alcohol use disorder to about 2%. And what we found was that tracking people over time, their depression scores improved. Even the more severe people got into the non-ill level on average. Same was true for alcohol use disorder. So this was a technology-supported service that was able to screen, treat, and build out in a system where there wasn't any mental health care. So in systems that have good primary care systems, you can do this in low and middle income countries. But it's the same kind of thing we can do here. All right, so now re-engineering care to make it more efficient. So this is a project that's going on now that I wanted to just tell you about. And we have a number of these projects. Actually, in one of the programs tomorrow, you'll hear about a similar project in gastroenterology by Jesse Salwin Demers is going to talk about it. But this is in our anxiety disorders program. So we were overwhelmed by people seeking anxiety disorders care. And we found that we could put someone on a waiting list, and maybe a year later they'd be seen, which isn't really what you want when you have an anxiety disorder. So we were thinking about, how do you actually get people into really good care? So what our anxiety disorders leader did was he screened people with really evidence-based screener type things and tried to rate what's the nature of the difficulty. It's a triage kind of device. And then he took the first quartile and provided clinician-guided self-help, because there's some good self-help teaching people about anxiety. How do you think about it? How do you treat it? The next quartile, he had group psychotherapy. Next quartile, biweekly individual therapy. And then the more severe people, weekly psychotherapy. And then if people weren't able to get the care or get the quality of improvement they wanted, they could move up to a higher level of care. But what it meant is that he could treat many more people much more quickly and get people into care in a fast manner. So this kind of thinking is a way to get better care to more people. All right, so then we also need to build out the workforce. And what we understood is that we didn't actually want more psych nurse practitioners. What we wanted was more really well-trained psych nurse practitioners, because it doesn't help to just have more providers. You want providers who actually know what they're doing and are very good at what they do. So we just turned up the volume and turned our attention. We already had good training for doctors, we had great training for psychologists, and we started to turn towards nurse practitioners. And we went in 3 years from training 7 a year to 28 a year. And on the map shows where they ended up. So we're building out psych nurse practitioners, quality nurse practitioners across our region. So it's a way an academic health system can leverage that knowledge and touch lives across the Twin States. People tend to live where they train. And then in addition, Sally Kraft's here, but in partnering with Population Health, we have been engaged in echo projects where you take knowledge and you spread it out across the region through these educational programs. And this is one that I think was supported by a HRSA grant and that focused on school-supported mental health. And people came from, people flocked to these educational programs. We're very engaged in them. And so it's a way of taking knowledge and supporting more and more people who then know how to care for the students who are in their schools, which keeps, if you can get care close to where the student is, they're less likely to turn up in the emergency room, where they might wait for a long time for hospitalization if they need that level of care. All right, so these are just a few examples of where an academic health system can take its knowledge and understanding and then try to leverage it to touch more lives through increasing efficiency, through training, and through technology support. So this is Justice Broderick, who has been going to all the high schools talking about mental health and on the radio. And on the right, I show that the Prouty, which is the cancer fundraiser that happens every year, this year got $5.5 million. My goal is for cancer to Prouty to get $10 million, and for our psychiatric services to get $10 million as well, because I think that the seriousness at which we go at cancer is the same seriousness that we should be going at mental health, so that all of our lives could be enhanced. Thanks.
Thank you, Will, for that great talk, and good morning, I think, still, everyone. So I'm going to speak on a number of things. I think I have a particular view of behavioral health and the behavioral health landscape, and I think it's important to recognize that, the behavioral health landscape varies tremendously, region by region, state by state, sometimes even within states. Like Manhattan, what's in Manhattan is very different than in Queens and in Staten Island. So I want to make sure people understand sort of my background, which is predominantly in New York, also in Connecticut as well. But I think what I want to sort of emphasize to folks is that I think New York, in comparison to many other states, we've got a richness of behavioral health resources and services. And by behavioral health, just to make clear, I'm talking about mental health and addiction services. And so in comparison to other places, you won't believe the kinds of services that we have across the continuum for so many different types of conditions and levels of severity of illness. What's important to note is that just because we have more, it doesn't mean it's better. And I think when we're talking about access issues and we're talking about quality of care, just because we have more, it doesn't create a better situation per se, it creates another level of complexity. So there's a couple of things I'd like people to get out of when we're thinking about access. It's not just about more. So just to give you a little bit of background, as simple as I could make it in New York, a person with a behavioral health condition in New York, and this is a very simplified diagram, there's a number of different places that they can get care. In New York, mental health services and substance use disorder services are regulated separately. There's literally 2 separate agencies, 2 different sets of regulations, different payments, et cetera. There's also certainly inpatient emergency services, community-based sort of recovery-oriented support services. So that's sort of like a little bit of a summary of some of these. You'll see a slide later on which gets much more complicated than this. Then, of course, we know that people with behavioral health conditions, as Barbara noted and as Will noted, they have a preponderance of physical health conditions. They also have to navigate the physical health system, right? And it's great because we've got all these care coordination and care management and care navigation services in New York. Wow, we've got so many, right? But the problem is they don't necessarily communicate with each other. The patient gets called sometimes by 3, 4, 5 different care managers or care coordinators, and they don't want to talk to anybody anymore. So the very sort of glue, which is supposed to help glue the patients together and with other providers, that's not optimally working either. And at the end of the day, what ends up happening is that there's very little coordination between programs, between providers. And it's so complicated, and this doesn't do justice to how complicated it is, that even behavioral health providers don't necessarily know which programs are right for which patients. So again, we've got lots of programs. Our New York State Medicaid covers an unbelievable amount of services under Medicaid, but it doesn't necessarily mean that people are getting into care. So I talk a lot about reimbursement or payment disparity because when we're talking about access issues and workforce issues, which has always been a problem for behavioral health services, even before the pandemic, that was a crisis for us, for like 50 years, right? Quality of care, improved outcomes. It feels like there's actually a lot of money being thrown at behavioral health, right? There's a lot, billions of dollars have been thrown at, and it almost kind of feels like it's like throwing spaghetti at the wall, right? And it's great that there's money, and it's great that it's being paid attention to. But when I think about how do we solve the access and workforce issues, it's great that there are more residency slots. It's great that there's more grant funding. It's great that there are new programs being funded, et cetera. But if we really want to start to get at these issues in a more sort of sustainable way, I think we need to look at root causes or root drivers of things, right? And people don't like to talk about we need to get paid more. But the reality of it is we need to get paid more, right? And I don't know why. I think, in psychiatry in particular, we don't like to talk about money. We need to talk about money because that's the reality of it. Because we are not paid fairly, and I'll explain what I mean. We're not just complaining we're not being paid fairly. We're not being paid fairly. So I think people are familiar with the Parity Act that happened in 2008. And it's wonderful. It's not to say, this was a huge step forward for behavioral health. But at the end of the day, and it's really important, it was really more focused on benefits and coverage, right? Utilization review practices, all those kinds of things, and it's really important, right? But the key thing is that they want to make sure that it's in line with whatever physical health coverage is provided and the benefits. What this doesn't address is one step kind of below is like, well, is there a structural methodological inequity into the way that behavioral health services are paid for because the way our payments, for the most part, are fee-for-service, CPT-driven, DRG-driven, whatever in a system of payment is fundamentally methodologically based on, it's really based on the kinds of assessments and treatments and interventions that are more in line for physical health conditions and does not necessarily recognize how it's different, although there's a lot of similarities, how it's different for many behavioral health conditions. And so that's what I talk about with reimbursement disparities. And I think for a lot of people who have behavioral health conditions, particularly those who are on Medicaid, this also represents a health inequity, basically. A reimbursement disparity in behavioral health is ultimately a form of health inequities. It's a form of racial and ethnic inequities for people with behavioral health conditions. So just to give an example of what I mean by we're not paid adequately. So for example, Greater New York Hospital Association is a major trade sort of advocacy organization in New York. They did a study with our help, and they found that in 2019, this is before the pandemic, in 2019, Medicaid, New York State Medicaid, paid only 64% of costs of an inpatient psychiatric hospitalization. You kind of wonder, why has there been a decrease in inpatient psych beds, right? I think New York, if you actually look at the data, they were technically overbedded, quote unquote, per capita, but regardless, there's not much to drive here, right? Well, we talk about then, okay, well, inpatient isn't the only answer, right? What about outpatient? Hospital-based mental health clinics in New York State did not get a Medicaid rate increase in the base rate for 10 years, not even a cost of living increase for 10 years. So where is the incentive for, and you need financial incentives, right? Where is the incentive to create sustainable behavioral health programs? Not every place, and Sinai has a tremendous commitment to behavioral health. It's in part because we have 2 psychiatrists leading the shop, but there's widespread understanding. But that's just not possible everywhere. It's not fiscally possible. And so if you're underpaid all the time, how can you create a sustainable level of care across all different levels of care? The other thing to note is that the issues are not just in Medicaid, okay? So actually the inpatient psychiatric hospitalization cost for Medicare covered only 80%. Again, that's probably not tremendously different for physical health, right? But oftentimes you can sort of make up for it, right, in the commercial end. The study on the top that I'm showing you was an analysis that was done. It was a nationwide claims analysis of commercial claims, and it compared the average payment rate for the exact same CPT codes, like for example, 99213, 99214, for people who had a behavioral health diagnosis and how much a psychiatrist was paid versus a non-psychiatrist paid, like a PCP, an internal medicine doc, a family medicine doc. The psychiatrist was paid always lower by 15 to 24%. It was only when they went out of network, which of course that just puts the cost to the patient, that got paid a little bit better, basically. So you can't even make up for it on the quote unquote, make up for it on the commercial side. We don't get paid adequately at any sort of major sort of, source of funding, essentially. Which is why so many times, yes, there's great funding, there's contract funding, deficit funding, all kinds of stuff, but that's not sustainable. And so until we arrive at a more sustainable form of payment, we're always going to be addressing with workforce. How can we get more workforce, quality workforce, if we're constantly worried about how to keep the lights on, right? How can we create more programs if we're constantly wondering about how to keep the lights on? And most importantly, how to assure quality of care? How do we get great psych NPs, right? When we're constantly just trying to make ends meet. So if we talk a lot about valuing behavioral health, when we say we value behavioral health, we have to pay for it fairly. And again, it's easy for me to say we got to pay for it, and everyone is going to say, well, where is the money going to come from? But I think if we don't say it, it's never going to be acknowledged, and it's never going to be sort of upfront as something that needs to be discussed. So this is sort of my take on sort of big buckets for, so what is sort of underlying driving reasons for, this payment disparity? And it's beyond things like just higher rates of denials and just low Medicaid rates, et cetera. It's like, so why are they low, right? Why are they not fully capturing things? So at a very high level, the first thing I'll tackle is this quote, behavioral health is not one illness. And, I think sometimes, not everyone, but if you're not in behavioral health, sometimes I'm in audiences or groups where people are not predominantly in psychiatry or behavioral health, and I sort of get the feeling that people think that behavioral health is like one condition, basically, right? It's not obvious. There's hundreds of conditions, subcategories and subgroups of conditions, and importantly, the prognoses, the treatments, the frequency of care, whether something is a chronic illness or an illness that can have a more sort of, quote, relapsing and remitting type of course, or is truly like a single episode illness. There's tremendous variability between all these different diagnoses. And so there's different types of psychotherapies, right? There's different types of interventions that can be used. We have, quote, procedures too. We have ECT, we now have ketamine, we have all kinds of different things that we can use. The other thing to recognize is that, and so despite the fact that we've got all these different types of diagnoses, there's also this weird sort of artificial split due to payment and regulations, in part because I think it was an attempt to try to pay for things fairly, but in reality, people who've got a primary substance use disorder or primary neurocognitive disorders like dementias or certain developmental disorders like autism, if that is your primary diagnosis, you cannot be treated in a mental health clinic. You cannot, if that is your primary diagnosis, it can't. So you can imagine, it's not like these live in isolation, right? People will have multiple comorbidities. And you can imagine the poor person and the provider trying to figure out, where do I go? Well, I have both an alcohol use disorder and I've got PTSD, and I don't know which place to go. And that's particularly an issue for New York because we've got this split arrangement here. But it creates a level of confusion and difficulty. They got to go through repeat assessments. They get tired. They get disengaged. It's frustrating, to say the least, right? And so this adds to, at the same time, even though it's not one illness, it's always the sort of levels of sort of stratification and separation to try to figure out how to deal with certain disorders separately, especially payment-wise, creates a sort of other level of confusion. This is a very simplistic overview, and this is because I always like kind of compare sort of at a macro level, sort of what's the behavioral health care system look like versus what does a physical health care system look like? And I know this is very simplistic, but to me there's sort of like a rhyme and reason, for the most part, to how the physical health care system is structured. There's sort of clear levels of care. There are clear sort of, and you can sort of generally kind of group them into certain kinds of major groups, right? We are technically, by we behavioral health, we fall into the specialty care group, right? So, but it's understandable, kind of. And this is a slide that I said, if this gives you a headache, that's the whole point. This represents probably about 60 to 70% of the different types of behavioral health services in New York. And this is what I mean. Wow, look at this. We've got CPEPs. We've got school-based mental health clinics. We've got assertive community treatment teams for the most seriously mentally ill. We've got residential treatment and all kinds of different options for housing for substance use. But think about trying to figure out, well, where do I go? Who do I call? Which one is right for me? When can I go to detox versus inpatient psychiatric? And look, there's all kinds of difference in inpatient psychiatric, right? So if this is confusing, this is confusing for me, confusing for everyone else. And so I'm going to stop complaining a little bit, or more presenting facts, and sort of say, when we look at something like this, I sort of want to sort of organize it better. And if we sort of look back at that sort of other organization of how the physical healthcare system is organized, then start to think, well, is there some way that we can start to organize these services into at least sort of more distinct major levels of care? And especially, how can we create connections between these levels of care? Because setting up a clinic is not going to be the answer. Adding 15 more psychiatric beds is not going to be the answer. Adding 30 units of housing is not going to be the answer. How is it all connected, right? And we're going to get back into this level of care, this continuum later on. So I'm not going to go into every one of these, but these are sort of really sort of concrete types of reasons that sort of go into why, at least I think, that our services don't necessarily fit neatly into the traditional healthcare payment framework. And so I'll just point out a couple of things. We're talking a lot more about social determinants of health, right? How important it is, regardless of your health condition, how important it is to assess and to help try to manage those better. The reality of this, psychiatry and addictions, we have always assessed social determinants of health. We have a psychosocial assessment that is part of our basic psychiatric evaluation. We're always evaluating housing, income, family instability, relationship instability, whatever all other kinds of stresses. So we need to do a better job of actually helping them manage and getting them the kinds of services that can help manage these better. But it's not like we've ever gotten paid more for them. We just have to do it. That's part of what we do, right? We're always doing there. And moreover, it's usually one person, right? We don't have, if you're paid at 64% of costs, we don't have the luxury of hiring extenders to do some of this work. We also don't have, quote, procedures as traditionally defined in healthcare. But I kind of think of our procedures as we actually have assessment scales, and we have scales that can measure progress, right? But no one pays extra for those, right? And who's going to have to do them? It's usually the single provider. We can't delegate out portions of psychotherapy. You can't have a nurse or someone else start one piece of psychotherapy and then hand it off to the psychiatrist, right? there's a lot of different things that are sort of different, that it's not just to say that psychiatry is different. There's just some fundamentally different pieces to the work and the workflow and the way that the work can be shared or divided up. And it just doesn't, it's not to say that it's wrong or right per se, it's more that it just doesn't fit into what is typically valued in our traditional payment system. And so the last piece, I think, in terms of sort of where, again, this reimbursement disparity comes in, when I talk, is hidden costs. And there's lots of different hidden costs. I could go into, you know, there's tremendous hidden costs, and when you have all those different types of services, there's all different kinds of billing. I had to become a revenue cycle expert. I had to learn about G codes and HCPCS codes and billing setups and getting down denials and write-offs, because the way that we're paid and the codes and the setups are totally different. You have to account for all of that and do that work. But in part, part of that is coming from essentially these regulations. We are probably the most regulated state in terms of behavioral health in the country, New York. And so this doesn't apply to everybody, but a good number of these do. So it's not just to say, oh my God, there's lots of regulations. When there's lots of regulations, there's a consequence to them, right? You can't just, there's a follow-up that you need to do when you have regulations. You need to make sure that all your clinical documentation is in order, right? Your EMR has to be set up properly, right? And then you have to make sure that the EMR is actually capable of building the right kinds of templates and reports for you. Well, most of the EMRs, and namely the big one, Epic, and no disparaging to Epic, it's not necessarily set up for a psychiatric or an addictions template, right? If you want something that has a better workflow for that, you have to buy another module, right? And again, if you're paid at 64% of costs, where is that additional money going to come from? Then you need to have specialized expertise, right? And that's partly why I have my job, right? Because it's so complicated. Someone has to understand and interpret these regulations. And this, people have to actually audit, right? So again, if we're not being paid enough and we have all of these other administrative burdens, whether it's billing or documentation or clinical regulations that we have to work, we need these additional resources. It's sort of a vicious cycle. So, enough with the complaining, right? So what are we trying to do about it at Sinai? So this is just to give you an idea. We are a very large healthcare system, and we're one of the largest behavioral health providers in New York State. And you can see that we have a large variety of services. We have purposely, over the past, the 5 to 8 years or so when I was running the service, there was a deliberate sort of strategy and plan to say, we cannot be everything to everybody. We had, this looks a lot now, we had something like 45 to 50 different programs, right? Sort of like when you can't focus on anything, right? We said, we need to focus on treating the most complex patients, those with medical comorbidities or psychiatrically complex, who have complex comorbid addiction and psychiatric disorders. And we need to think about sort of really what our expertise is instead of being everything to everyone. And we have to organize ourselves into levels of care. And so this didn't happen overnight, and I didn't think of this overnight, this was over time. And so this is actually a streamlining of the kinds of services that we have. So we do, in behavioral health, we do have to think about streamlining and efficiencies and really thinking about what's your core purpose, and also sort of then thinking about who are the different partners, because to create a sustainable behavioral health care system, you can't do it yourself. You have to think about other partners, particularly out in the community. So along those lines, over the past couple of years, we started to work on this model, and so we said, okay, we need this continuum. We also need to address certain key challenges that exist, that there are actually gaps in the continuum. There's a discoordination in the continuum. There's too much of this care coordination kind of stuff, which is not geared towards people with behavioral health conditions. And I think first and foremost is really, how do we remove this from a reactive to a more preventive sort of model of care? Because as for all of the focus on EDs and inpatient psych, and in many parts of the country, there really is a dearth of inpatient psych, right? And so, but the larger sort of, when I step back, when I think about that is, if all the attention is on inpatient psych or on emergency psych, what we're actually saying, and if all the money is directed to that, what we're actually saying is, we're waiting to take care of people after they've tried to kill themselves, or after they've tried to overdose, or after they've become so psychotic that they cannot function at all. Why is that right? Because that's what inpatient psych is. That's what an emergency psych visit is, right? Why is that more important than how can we build up the rest of the continuum so that people don't have to get there whenever possible? And so that's what we've tried to do, and we did a number of pilots and a lot of different things over the past several years that informed us in building this new center that Barbara was referring to. So this center, which has this very catchy name of the Mount Sinai Comprehensive Behavioral Health Center, there's two really unique things about it. And I think the first thing, and maybe not quite as unique, is that we have a number of different services all in one building. But it's not just that it's these different services. We thought about what are the key services that represent key components of the continuum of care for behavioral health. So that's one. Because just physically having it all together creates a lot of efficiencies and improvements for patient satisfaction, et cetera, patient experience. But the second piece is, how are all these programs functionally communicating, collaborating, working with each other? Right now, a lot of our services are actually in one building. Doesn't mean that the care is connected, right? Just because you're physically located together, it doesn't mean that it's connected. So the other piece is, how can we create functional connectivity? And that's both through tech and I think especially for people with behavioral health conditions, through people. And so we think that this will be hopefully this is certainly different for New York, because it's really focusing on levels of care and building a continuum as opposed to focusing on certain programs. And so these are the services that will be in the center. And again, it's a little less important like what's like actually in these buckets. It's more that we've got inpatient, crisis, subacute or intensive outpatient, and more traditional outpatient, but that it's an integrated outpatient mental health, substance use, and primary care. And of course, we'll use telepsychiatry or telebehavioral health. And we're adding in new programs because, again, just having traditional clinic care and inpatient care, there are many things that can be available in between, and that's particularly the subacute and the crisis services. Those two levels of care are critically important to helping prevent emergency level care or inpatient level care. And that in particular, how this is going to be connected, and I'm not saying this is what it's going to be like on day one. We will figure this out as time goes on, but that we have to have integrated clinical workflows, and that we have teams of people who will work with select patients who are at high risk of either having a significant relapse of illness or worse, and for example, that they're being discharged from an inpatient setting, or they're being discharged from an emergency room, or they're actually in our clinics, and our clinicians are recognizing this person is not showing up, this person is at high risk of suicide or high risk of decompensating, and this team of a peer counselor and a social worker will reach out to them regularly, not just once, not just twice with a phone call, but just continuously. And they will serve as like the glue for these people. They will interact with the other care coordinators, all the other providers, because for a subset of people, that connectivity is really important. So that, I could go on, I can put a whole presentation together about the center, but that's just, oh, sorry, wrong one. That's just a quick overview. But ultimately, and I think not everyone can build a $140 million, yes, Mount Sinai invested $140 million to put into the center, right? Not everyone can do that, right? I'm very grateful to Mount Sinai. But the reality of this is not going to necessarily work unless it can be replicated in some way. So there is sort of like a fundamental model behind this, which we again have this really catchy name of a comprehensive integrated behavioral health model. And it's essentially saying is thinking about the continuum, not just individual programs, but continuum. And a continuum that includes this functional integration, that you have to think about outpatient in a greater variety and in a much more sort of diverse way. Recognize that behavioral health providers actually function as a gatekeeper. They perform a lot of the functions that, quote, a primary care provider does, right? They should get recognized for it, monetarily too, right? And so, and of course, integrating physical health care and care coordination specific to behavioral health. And so I think we all learned we need to create resilient healthcare systems. And so if we just keep thinking about throwing money at single programs or single populations, that's not going to do it. You need to think about the entire continuum and how to shore up all parts of the continuum. And so essentially what this model says is that it's not that you have to have everything that's in our center, and we don't have everything necessarily, but that you should really have at least one from each level of care, and you don't have to do it all. You can find partners to do that with. But again, it's that functional communication and collaboration at the individual patient level and at the population level. And last but not least, it's sort of, and this is what we're trying to say, and hopefully this will come to bear, that there's a primary physical model, like our behavioral health center, where literally everything is physically in the same building, which does make it easier, but that there is a virtual model. And we're actually building this out for our other services. We have other hospitals uptown, and sort of thinking about how can we do this virtually, where that functional communication and integration, that really serves as a crux of the model. And so, we'll learn and we'll see. We'll hopefully have some good results from this. But, we did this because we felt like there's been a lot of efforts and a lot of good work that's been done in New York and elsewhere. I don't want to diminish all the great work and efforts that's been done. But it's sort of like we felt like we had a responsibility. We're one of the largest behavioral health providers in the region. We needed to do something, to try something dramatically different, essentially. And hopefully we'll see some good results. And if we don't, we'll learn from it and bring better results later on. So that's the end. And I think now I turn it back to Barbara, right? I think? Yep.
I want to thank you both. Those excellent, excellent discussions. Please feel free to line up. There are 2 mics for any questions. I'm going to kick it off. We've heard multiple times today, well, I'm going to ask you, about telepsych. And personally, I was working in the ED this week. I had a patient, 17-year-old, suicidal patient, very violent and aggressive, transferred from me from Brooklyn's ED. I have pediatrics, but I don't have pediatric psych at my facility. And ultimately, the patient was transferred to yet a 3rd hospital for admission. Nowhere along the journey in the beginning, did they think about using telepsych? Why hasn't it caught on? It's been out there 20 years.
Well, with your patient, what isn't clear, by the time the person is violent and aggressive in the ED, they need some more care that's safe for them and for the community. The issue that we were talking about is really projecting care out so that you're finding people in the schools, finding people early on so that they can get access to quality care from the start. Telepsychiatry is really helpful. It decreases driving time, either for the provider to go where the patient is or for the patient to come where you are. It doesn't cut down on the actual amount of time it takes the provider to do the care. So if I have a busy schedule seeing patients back to back, it doesn't really matter whether those patients I'm seeing them on the screen or in the office. Actually, nowadays I go back and forth as my afternoon goes on. It takes me the same amount of time to do the care. The telepsychiatry care has some advantages. You get to see the people's pets. It's sort of like a virtual home visit sometimes. And so you do get some quality of their life that you might not see if they come into the office. But it also lacks the sort of human part that you can get when you're talking to someone in the room. Tele just isn't quite as intensely humanly connected. That's why we're liking being at a conference in the same room rather than by tele. It's the same thing when you're doing clinical care. It's more effective. So telepsychiatry is hugely helpful, but it doesn't solve the whole problem. You still need the person there doing the care. It doesn't take that time away.
Okay. I see we already have people lined up at the mics.
Yes, thank you for your presentations this morning. My name is Eileen Lynch, Dartmouth College 83, Dartmouth Medical School 87. I know you referenced how mental health has very much affected our youth. So as a little bit of background, I'm the mother of 3, almost a 3rd college graduate, 2 that graduated Dartmouth. And I was wondering what your thoughts were on the responsibilities of colleges and universities in dealing with the mental health crisis on campuses, given that many of these diagnoses are made in those years that the colleges own their students. And I know from my own experience here, as much as I love this college, Dartmouth really has fallen short and is hoping they're making some great headways. But what are your thoughts in general on the responsibility for mental health on campuses of the colleges and universities?
Do you want to start?
Let's see, how can I phrase this? I think if, we forget about how young people are, and that people are still, quote, in development, in emotional and psychological development during that period of time when they're in college. Not all, but many of them. And I think part of that is there is then that responsibility that when there are struggles, emotional and mental struggles or other types of struggles, there is a responsibility. It is hard, I think. It's a challenging to set up, certainly to get enough people to, just for the workforce issues alone. I think there are unique complexities, particularly within the boundaries of, being a student versus an employee and a provider. Those are sort of tricky kinds of things to navigate. And so that needs to be thought of when developing those kinds of programs, basically. But I think there's no question, just like in many hospitals, we provide mental health services or social support services or what have you to our employees. I don't think fundamentally that concept of that should be any different for students of a school or an institution. It's a way to take care of our own, basically.
So a couple of things. One is that one of the wonderful things that's happened is that as we have gotten better and better at knowing how to care for people with psychiatric difficulties, younger people are getting treated for psychiatric difficulties earlier on. And that means some very bright people who previously their psychiatric difficulties would have led them to not be able to get into Dartmouth or other institutions, now have the support that allows them to actually gain admission and come to colleges. So you have colleges that are caring for people that have had more difficulty with psychiatric illness because the treatment's been good. So that's the good news. I think of this as a population health issue. You have a population of people, the young people, so then you have to think about what are the issues that are likely to be helpful. So you want to make it a really low threshold for getting into care. You want to make it easy for people to get into care. And then beyond that, and so I think the colleges can put a lot of attention into that. Then beyond that, you want to create an atmosphere that is going to be screening and understanding, having enough eyes on the students to understand when someone's starting to have difficulty. And I think you can do that by educating all those people that run into the students, the professors and others, about what to look for and how to think about warning signs and help them to know how to help people get into care at those times. And then beyond that, there's things that really help, like having extensive efforts to create community within colleges so people feel they belong and they feel they're connected. And so that's more well-being kinds of interventions. So I think the colleges, I know Dartmouth definitely is turning towards this as an incredibly serious matter. They want the students to thrive. One of our psychiatrists now has a day a week in the provost office just working on this specifically, and he's great. He's already been working on it in the medical school. But they're making a lot of headway. Medical students are also at risk population, so they need a lot of support as well. So it's a great question.
Thank you.
Thank you.
Rob Green, MHCDS class of 14. This is mostly for Dr. Lim. So you discussed the difficulties of the fee-for-service payment system with mental health care, and I agree with you. As an alternative, if you think about population payments or total cost of care, those have their own issues as well. And specifically, how would you think about, how does an institution split up what part of the PMPM should go to behavioral health? And then within that, how do you take that payment and translate that into paying for staff and clinicians?
Great question. So we actually did, I'd referenced pilots. We actually did do a state-approved 2-year VBP pilot in New York State, serving the most complex, mentally ill, with often comorbid substance abuse and physical health conditions. And so by the end of the second year, we touched probably at large of probably about 400, 450 patients. In terms of more routine contact, it was probably more in the 250 to 300s. But of that relatively small group of people, we saved $1.3 million in Medicaid. So that, and all of that, almost all of that, was from savings in the medical side, right? There was an actual increase in spend in behavioral health services, which is to be expected, right? A very modest increase, and all the savings went there. So part of that is sort of internally then, where does that get allocated to? Again, we're very fortunate. It was sort of understood that this was, maybe it doesn't show up in an exact P&L for your individual service, so it was a system-wide thing, but that it was at least recognized by our leadership that there was this, that behavioral health added $1.3 million as part of our shared savings, and it wasn't a shared savings, it was actually a total cost of care model. So, I think that gets to this larger issue of basically, yes, so we were able to find a way to account for it and give behavioral health credit. How do you systematically do that? And also, moreover, that took a tremendous amount of resources and time. And so there's no upfront, right? You sort of get it at the end, kind of. You have to make sure that you get some sort of upfront funding or sort of some sort of changes to the cash flow so you can get more, some cash flow up front or something like that in order to have the kinds of resources to be able to carry out something like that. So I don't have an answer to that question, but I totally agree with you that there has to be some sort of systematic way to help behavioral health services get, quote, financial credit, certainly within institutions, but really in the larger system, because the savings is going to come from VBP, it's going to come from the medical side. There's no question about it. Yeah. The integrated care, right?
That's what all the collaborative care programs show, it costs twice as much to care for someone with diabetes if they have diabetes and depression. If you get really good behavioral health care integrated into primary care, it costs a little bit more, and the savings is in the emergency room and inpatient hospitalizations for their general medical issues. That's where the money comes from. Yeah.
Hi, Mark Woody. I'm from the class of 20, and the question I have when you were talking about a 10 experience is a key component, and I have responsibility in our health system around cardiology and oncology is drug spend. And so I haven't heard a lot in the whole strategy on behavioral health, which is a big strategy for us in our system, around how we're approaching pharmacy and the role of pharmacists and drug spend and precision medicine in pharmacy, because I know, because I do some work on our employee health plan, is the amount of money we spend in that space. And I'm wondering about your perspective on drug spend, pharmacy, utilization of pharmacists within this space, and alternative models that I haven't really heard about or seen. So that's my question.
I think that there's an incredible role for clinical pharmacists in behavioral health that is underutilized currently. One of the challenges that we see in our field is that when people are acutely ill, they get on a lot of medicines, and as an outpatient psychiatrist, most of my job is helping people get off medicines effectively. Because there's a lot of pressure for people to get out of the hospital fast, so the treatment timing of adding things is faster than what you'd expect for the medicine to actually work, so they leave the hospital on too many medicines. So outpatient care in psychiatry is deprescribing for the most part, and getting people on the least amount of medicine that works for their condition. The clinical pharmacists are really good at understanding side effects, understanding interactions, helping guide. We use them for consultations all the time, but I think they could be used much more better, much more frequently.
Yeah, I agree with you. At least during my time, I hadn't really focused a whole lot, there you go, on pharmacy spend. We did, for a period of time, spend a lot of time focusing on one particular medication, which will remain unnamed because of its exorbitant costs. And some of it, a lot of it had to do with, just like for the same reasons why you're saying that people are coming in on polypharmacy, is what are our providers' prescribing practices? Why are they prescribing certain antipsychotics for sleep, for example, when it should be used for other things? And I think partly it's because it's a challenging endeavor, to be very frank, changing physician practices or prescriber practices. It's not to say we shouldn't do it. We haven't really looked at the clinical pharmacist role, but I think, potentially as time goes on with the new behavioral health center, because we will have our own pharmacy, that is being more actively looked at. So thank you, that's an important point.
Just to add just one thing, because it sort of came up in your statement, is that when you're responsible for the cost of care for your population, then you really care about behavioral health. So healthcare systems, if they're self-insured, behavioral health is among the most expensive conditions. And so it's really short-sighted for our organizations to not be focused in on providing quick, excellent access to behavioral health care early on. It decreases costs over time, and we should be investing in that. But you have to do it on a population perspective, because fee-for-service care in our field does not pay for itself. If we hire psychiatrists, they cost twice as much as we can get in billing, keeping them really busy and efficient. So the system is not built correctly except for population-focused care. But if you care about the cost of population, you're on the line for it, then you invest in behavioral health. That's why the VA invests in behavioral health and primary care, right? Because they're responsible for a population.
Good point. Sandy?
Hi, thank you for great talks. One area I didn't see mentioned, if you want to share some thoughts for the panel, is mental illness in women's health and maternity population. If you're doing any work in that and willing to share any thoughts on that, thank you.
Are you doing a whole?
So we actually have a wonderful program called Moms in Recovery, which is for pregnant and parenting people who have substance use disorders, and that care, people often will be reluctant to seek care because they feel they'll be blamed or hurt. But however, during pregnancy is the time when people are more motivated to seek care for their substance use difficulties. So if you can make it really easy to get in and create group care where people talk to each other, support each other, and then you also have to build in a lot of other supports for food or for general medical care. Actually, we get the OB care done much better when they're in our program because they're already engaged with us in the substance use realm. So that's really helpful. We also, it is a little bit of a subspecialty area, prescribing for pregnant people for psychiatric difficulties. So you do need experts who can provide in a consultation service so that people around the state, around the country can call up to ask about their patient and how to address the psychiatric needs when the person's pregnant, because it's an evolving field and you need specialists who can then offer consultation.
Final question?
Thanks so much for a wonderful panel presentation across all three of you. Similar to Sandy's question, I'd be curious if there's been much of a focus on the pediatric realm. Barb, you brought a great focus from the COVID pandemic context into it. We're seeing an explosion of depressive disorders, anxiety disorders among kids. I saw a recent study that estimated the new diagnosis of autism disorders in kids is also exploding, and that comes with a tremendous expense with it typically. So I'd be curious if that's been a focus of the Comprehensive Behavioral Health Center, and if there are any sort of partnerships. Sometimes we're seeing health systems work with focused autism providers, for example, to work with that specific population. So just curious if there's been any sort of partnerships and how you're kind of dealing with the mental health and behavioral health issues among kids.
So in reality, for the actual new center, we do have a small pediatric psych clinic, but the population of kids that we serve in that even currently is relatively low. Throughout the rest of the Sinai Health System, we have a very robust child psychiatry outpatient service, including emergency services and even an inpatient psych unit. Interestingly, and I routinely check in with our PDED colleagues, because everywhere we're hearing about the explosion of kids waiting. And yes, we do have kids waiting, and Barbara, correct me if I'm wrong, it's just not as bad. For Mount Sinai, it's not as bad as what I hear. And I think it's in part because we have these kinds of services available already for us. So which speaks to the fact that we've got like a mini continuum of care for children. We've got inpatient psych, emergency psych, outpatient clinic. We even have in-home home and community-based services for kids. So it again speaks to if you have that, it can make a difference. I think what an increasing focus on is that, again, with kids, you're waiting for them to come to you. When most of this, to Will's point, you want to try to get to them before they come, before it's decided that someone needs to see a psychiatrist, which is in the schools, right? So, for example, there's a lot more, quote, funding for school-based mental health programs. There's always been school-based mental health programs in New York. I don't know how it's like in other states. It's been hit or miss, quite frankly. And I think, but that's an area of, I think, that where significant focus should be placed on, and efforts, and training and education. And so I think you're quite right to ask about that. I think, fortunately, kind of at Sinai, we have not had quite the explosion that other people have had. But Will, I don't know what it's been like for you.
Well, there's certainly both regionally and in the news, there's a mental health crisis for children and adolescents. The pressure is up on this group, and I think COVID really helped push that because of the social isolation at this developmental time where you really want to be with peers. And I think that was part of the college, tragedies that have taken place over the last few years. Just that the isolation at the same time, you really need each other to get through this challenging part of life, so the demand outstrips capacity. There's no question. I think I think autism and intellectual disabilities generally in children, that's another area where you can do a huge amount if you can get good care to people at the right time. I mean, people can do really, really well. And adults too. I used to care for a lot of people with intellectual disabilities who were adults who had behavioral health problems. If you can do really good care, people can do extremely well. I think it requires these consultation services. New Hampshire and Vermont, or New Hampshire has for a long time invested in consultation services for children and adults with intellectual disabilities, and it's been funded by the state, and we've been providing the contract. So then we have subspecialists, who really know this area, and they both care for individuals. They do educational programs across the Twin States so that more and more people have the knowledge and capacity, and then they do consultations on the most ill or the most challenging situations, and that's the way to go. But I think we want to push out knowledge and understanding that subspecialists are not going to be able to do all the care. We have to be building out capacity across the system.
Okay, I want to thank you both. It was phenomenal talks, and I'm going to turn it over to